Hello and welcome to this edition of PCR Webinar. Today we are going to focus on TAVR and bicuspid aortic valves. My name is Jörg Kempfert. I'm a cardiac surgeon from German Heart Center in Berlin at Charité, Germany. My co-moderator is Professor Chen from Chengdu in China. And together we are going to discuss with you the prevalence and also the indication and techniques to do TAVR in bicuspid aortic pathologies. So we have an excellent panel here, and we're going to introduce each speaker before they actually cover their topic. And they have brought some interesting cases that are going to hopefully stimulate the discussion in regard to patient indication, but also technical details and sizing strategies. So the learning objectives are clear. So TAVR and bicuspid valve is an evolving topic. There's not that much data yet, and also the techniques for the actual procedure might differ from tricuspid procedures. So this is why we want to start with an update on the prevalence and the situation for TAVR and bicuspid aortic valves in China. And it's my honor to introduce my co-moderator, Professor Chen, to talk you through. Please.
Thank you, Jörg. It's my great honor to introduce bicuspid TAVR clinic update in China. This is the carrier registry. It's a recent observational study in mainland of China. Half patients, bicuspid patients in TAVR, and almost among all these bicuspid patients, 42% are type 0. And compared to the Western studies, we can find more bicuspid patients in TAVR, Chinese TAVR patients. And talking about the different morphology, more patients are type 0. From the according to the previous surgical aortic valve data showed as alongside the decreased age, the more possibility of the bicuspid patient. So I think the Chinese high prevalence of bicuspid related to the younger age, because in China, the mean TAVR age only 73 years old. Venus A trial is the first preclinical trial in mainland China using the domestic device. This is kind of expanding device. We can find talking about the procedure, more bicuspid patients lead predilation. And the clinical outcomes, only the minor bleeding more frequent in bicuspid patients. No any other difference between the bicuspid and the tricuspid. The vata flow is the another studies, and during the 1 year and 2 years follow-up, we can find no any difference between the bicuspid and bicuspid patients. Sorry. And talking about the hemodynamic parameters, there is comparable between the different and between the bicuspid patient and tricuspid patients. The S3, Edwards S3 device have been commercially available in mainland of China. According to the post-approved data in China, we can find the baseline, the younger patients in most bicuspid patients, and with the larger annular size and the higher left coronary artery height. But talking about the clinic endpoints, no difference between the bicuspid patient and the tricuspid patient. Also, in clinical practice, we using the TAVR procedure to treat the bicuspid patients, but there remains some technical challenges of TAVR in bicuspid patients, including the possibility impair the valve durability in long term, and how to choose the correct valve sizing, and how about the future of the combined autopsy. This is more common in bicuspid patients compared to the tricuspid patients. We use the Notice device to observe the post-CT after the TAVR procedure. We found the real occurring level of the bicuspid patients above the common annular level. We call it the supraannular level. We're using the finite element analysis to study. We found in patients with bicuspid patient, this was associated with a more pronounced tapering in space from the annulus and the less expansion of the frame than tricuspid morphology. We're using a kind of moderatory shaping to treat the bicuspid patients. We call it the moderatory shaping just because the unique predilation, we're using a kind of hourglass balloon. The preamble of the balloon was the nominal balloon diameter at the end level should not exceed 1.1-fold of the diameter of the corresponding root structure. And we do the pilot cohort study. We found if we using this kind of moderate reshaping TAVR, just the self-expanding device, we found the better clinical outcome compared to the previous methods using the cylinder balloon predilation. That's all. Thank you very much.
Thank you. Very interesting overview. I think we have one question here from Dr. Tang in regard to this presentation.
Yeah, thank you, Dr. Chen. So we all know that the BAV actually considered to be more difficult than the TAV. So, but why would you think the Asian people have the more BAV than the TAV than the Western country? Any biology mechanism of that?
Yeah, just from the epidemiology studies, we found the real prevalence of the bicuspid is almost similar between the Chinese patients and the Western population, almost the 0.5% to 1%. But I think the major factors contribute to the high prevalence of the bicuspid in Chinese TAVR patients just because of the younger age. Because, in our clinical practice and in our preclinical trial, the mean age of Chinese TAVR patients only 73 years old, almost 10 years younger than the Western population. Just because, alongside the decreased age, the more bicuspid patients were found in aortic stenosis patients. This phenomenon also we can find in Indian patients, because the Indian patients also the TAVR patients also younger than the Western population. So I think this is the major factors contribute to the high prevalence, high frequency of the bicuspid patient in Chinese TAVR patients.
Thank you.
Thank you for this explanation, and this does make perfect sense. So we have now learned that the younger the patients are, the more likely we are to face a bicuspid morphology. And we also are aware that these procedures might be more challenging than the tricuspid cases. And this is why it's my pleasure to introduce the first recorded case. And this is going to be presented by Dr. Zhang. And we're going to use these cases, we have a total of 2 of them, to discuss the details in regard to sizing, but also in regard to the technical details that you might need to change when coming from tricuspid cases. So Dr. Zhang, please.
Okay, thank you very much, Jörg. It's my great honor. So, okay. So this was 74 females presented with exertional angina and the worsen for 2 months. And you can see actually from the echo, it's a typical severe aortic stenosis. Also, you can notice the mean gradient more than 14. It's a 16.5 millimeter Hagrid. And also we calculated the ST score, it's 3.6%. So it's belong to moderate risk. So let me show you the CT analysis for this particular case. Actually, according to the CT analysis, it's a typical BAV case type 1 with the right and the left coronary fusion. And you also can notice there is a moderate calcification with the fusion site. And also, according to the analysis, the annual area was 300.4 millimeter square, and the LVUT area was less than 300, only 285 millimeter square. So it's a small body size lady and a small valve area. So we also do the circle method to select the valve. Actually, according to the circle method, you can see the annular area actually belong to the 20 millimeter sapien 3 valve. And also you can see actually the left coronary height is only 8. So at this side, you can notice between the orifice of the left band and the virtual valve, there is only 3 millimeter. So at this slide, you can notice the very, very lower left coronary height, only 8.7 millimeter. In terms of the RC height is also not so high, only 11 millimeter. So for this particular case, so at this time, I would like to have your options. Georgia, what's your option when you do the case? You are selected the SAVA or TAVA in Germany for these older ladies with a moderate risk patient and a small size anywhere.
Okay, so thank you for the question. So, I mean, if it's a moderate risk candidate and it's 70-something years old, and also according to the current European guidelines, we will have a thorough heart team discussion. And if it is a tricuspid case with a good landing zone for TAVR, then we will go for TAVR. If the landing zone is not so nice and there might be some risk associated in regard to PVL, but also pacemaker or even annular rupture, and the risk is low, we would have a discussion with the patient. And then most likely in such a case, we would go for minimally invasive surgical valve, as long as the operative risk is not too high. Simple because of the fact that we cannot predict an optimal TAVR outcome if the landing zone is calcified and not so device friendly.
Thank you. Thank you very much for your options.
So, Ida, I just want to ask you a question about this particular patient. And if we decide to do the TAVR procedure for these patients, which kind of device you will use? Self-expanding or balloon expandable?
So we can see the two factors we have to consider. One is the height of the coronary. We can see the low height of the left coronary artery and the low height of the right. And another factor will be the angle between the left ventricle and the aorta. So based on this, so I prefer the Edwards. So there's the balloon expandable valve than a self-expandable valve. So if we using the so if we are using the Edwards, so in terms of the size, probably I would choose the smallest one, which is the 23, because the circle we can see the 303. Is that right? I think James is the 303. So the size will be like the 23 size for the Edwards.
Actually, it's a smaller valve for this particular case.
The smallest one.
Yeah, I think just based on the area of merchant area, I think the 20 maybe is the candidate valve. But
do we have
20?
Yeah, 20 is available. Yeah, it's the smallest valve. Yeah, according to this case. Yeah.
Okay, Professor Wang, I have a question to you, and we can find the height of the left coronary artery is not very high. So, do you have some concern about the possible left coronary blockage? And if you have this concern, how to prevent the blockage of the left coronary artery?
You mean the left coronary artery is not high enough?
Yeah, I think the protection of the left coronary artery. How about your strategy?
Okay, I would like to use a small balloon to dilate to see the movement of the rupture and say do the angiogram to say what's happened during the balloon dilatation and decide to protect the coronary or not.
Okay. So Junjie, I think you can move forward.
Okay, I will show what I do for this particular case. Actually, during the procedure, actually there is some emergency situation. So can I show my slides? Okay. So actually, this case is a high risk for coronary occlusion, just as Dr. Wang mentioned. So for this particular case, actually from the peripheral artery, actually the iliac and the femoral artery is large enough, more than 6. So my strategy for this case is choose the right femoral access with the E-sheath. I will predilate with a 60 balloon to access the coronary risk. And in considering the left coronary height is only 8, so there is a high risk of conclusion. So I will use a guiding catheter and the coronary wire and use a balloon to protect the left main. In terms of sizing, according to the CT analysis, the aneurysm area only 300. So accordingly, SAPIEN 3 20 millimeter valve is suitable for this case with a nominal inflation. So in terms of height of the implantation, I think it's a standard position, 80 to 20. So before the procedure, I performed the coronary angiogram for these older ladies. From the coronary angiogram, you can notice there is no lesion for the coronary artery. There's normal CAG. So I think for SAPIEN 3 implantation, I think the co-plane view is always very important for every case. So although we got to the CT analysis at the table, we still adjust the coronary view. So finally, we get to the IO10 and the Carina 9. It's a very precise co-plane view for this particular case. So let me show my procedure. Actually, I insert I cross the stenotic valve with a straight wire, then put a pigtail in the left atrium and measure the gradient. You can see there is a very high gradient. Then I use a pre-shipped wire, it's domestic Chinese pre-shipped wire, put into the LV, and I do the predilation with a 16 balloon. Actually, you can see during balloon dilation, actually you can see there is the lift is actually very near to the orifice of the left main. Well, however, in regarding the safety, I use a guiding balloon and the coronary wire to protect the left main. So actually, during immediately after balloon dilation, the patient hemodynamic was unstable and the BP were decreased. And also the TE shows aortic regurgitation was severe. And even we use adrenaline to increase the BP, but still there is a very low BP. So emergency, we insert the valve. At this time, I think the pressure only 40 to 20 millimeter mercury. So considering, I think it's due to the predilation and also the small size LV. So at this point, the only thing we can do is quickly and precisely input and position the valve at the right place and make the aortic valve get to the normal function. So actually, you can see we insert the valve. Pardon. So after we insert the valve, you can see the BP was go back to the normal, and also there is only little less than 10 millimeter mercury for the gradient. So also from the shape of the valve, you can also notice the valve is not fully open, fully expansion. So as these scenarios, I choose 1 cc overfilling to do the post dilation for this particular valve. So you can see at the middle panel, it's a post dilation with 1 cc overfilling. And the right panel, you can see this is the final result. It's a perfect result with a very, very mild regurgitation, and also the coronary flow of the left main is normal. So this is the final result. So I use guiding engage the left main to see that the left main is didn't interfere with the valve, and do the final angio show good result. And also immediately post the procedure TE, so the valve is fully open and the flow is very good. There is no PVR for this particular case. This is a post-procedure at the second day before the patient was discharged. We do the TT for this patient, and the mean graded only 12 millimeter hungry, and the valve area was 1.4 centimeter square. Considering it's a small valve, the result is quite good. So this is my case. So actually, there is 2 questions for discussion. The first question is just Dr. Chen proposed how to protect this left main for this high-risk occlusion of left main. And another question is for this particular case, what do you think, how to prevent and deal with the hemodynamic collapse after the balloon dilation for this particular case? Thank you.
Thank you. Very interesting case, actually. So I think we should start a discussion in regard to your question. So maybe we start with potential solutions or potential suggestions on how to optimize hemodynamics and how to prevent collapse. I mean, we all have seen this, but it is in general relatively rare. It's relatively rare to see hemodynamic collapse due to aortic regurgitation induced by balloon valvuloplasty. It's more common if you have a failing surgical bioprosthesis, then sometimes you can, if you do a pre-dilatation, you can see this problem, but in bicuspid patient, it is not so common.
Yeah, I think for this particular case, actually the LV capacity is quite small. So I think for this particular case, the baseline, the diastolic LV pressure only 10. So as these scenarios, actually, we consider there is high risk after predilation for the hemodynamic collapse. So before we do the balloon predilation, we give this patient more than 1,000 normal saline for the hydration. But unfortunately, even we consider of this situation after predilation, due to the significant aortic regurgitation, the patient still occurred a hemodynamic collapse. So at this time, even we give adrenaline, the BP is still low, and at this time, so I think the only way we can do is so quickly input the valve.
So did you give the adrenaline directly into the aortic root via the pigtail?
I didn't give. I only use the vein. So your suggestion from the pigtail is take faster effect.
Yeah, so we always have a sterile syringe in the room with the adrenaline, and in case of hemodynamical collapse, it is a very good trick to give the adrenaline directly into the pigtail that is sitting in the aortic root, because if you give it into the vein and you have no circulatory output, as we all know, you need to wait until the epinephrine is going to come into action. So the trick with giving it directly into the aortic root in an emergency situation is very helpful. However, you then need to kind of accept the overshoot in the pressure that you're going to experience after 1 or 2 minutes.
Thank you.
So about the bicuspid patients, I think this is a higher risk of the hemodynamic collapse during the predetonation, because in bicuspid patients, the more patients are just pure aortic stenosis without the aortic regurgitation before at baseline. So if we do the predetonate and almost like this particular case have the severe aortic regurgitation, in this situation, it's very possible, it's a high possible to result in the hemodynamic collapse. So just based on this particular case, give us a hint. We might sometimes when we do the predetonate, not need the big balloon, just smaller balloon can safely predetonate. I think it's a key issue. If we meet the hemodynamic collapse, I think like the Junjie showed us, is very important. We should replace the device, the aortic valve as soon as possible.
Thank you, Dr. Chen Mao, for your excellent experience for this particular situation. So, Professor Wang Yan, what's your opinion for the particular case?
You mean for the collapse? If you're during the bicuspid, it's a rare happen, but one happen, you need to immediately to give the maybe the CPR and quickly to put the valve during this time, give the IV or in the pigtail to give some adrenaline like this to quickly to help the patients. But most important is quick to implant the valve.
So in addition to the hemodynamic collapse, you also have pointed out the importance in these patients that have often high calcium load to think of potential coronary occlusion. And I think it's critical to understand that usually it's not a direct occlusion of the coronary artery themselves, but it is more that what can happen is that the perfusion of the coronary sinus is impaired. And I think this is based on your CT workup. This was very sophisticatedly analyzing these potential options. And also this potentially led you to the decision to go 80-20 instead of a 90 or even 95-5, which is the usual approach. Most of us would treat a bicuspid valve. So did this alter your decision making, that you decided not to go too high to not touch the STJ in this particular case?
Yeah, I fully agree with for this high risk of coronary occlusion, and the implantation high is very important. For this case, I think 80-20 implantation ratio is very important and also very suitable for this case to avoiding the coronary occlusion. Yeah.
Dr. Kempfert, for your suggestion regarding the pigtail injection with adrenaline, so if the dose will be the same dose with the IV bolus, or that'll be like the larger dose or the smaller dose?
So typically what we do is we give 1/10 of the usual IV dose. And if this is not effective within 30 seconds, then we give the full dose, which is then obviously an emergent situation, and we are just about to crash to the ECMO or to the CPB. So before we crash to the pump, we will give the full dose directly in the epictel, but obviously if the pressure is recovering, then you'll have a significant overshoot and it takes a couple of minutes until everything cools down. But start with 1/10 of the usual IV dose.
Okay.
Okay, I think this was a very, very interesting first case example. And the idea of this webinar is to actually use a second case that is going to be presented by Professor Wang. And I am sure that also this case is going to trigger a lot of discussion in regard to technical details and tips and tricks in the bicuspid patients. So please, Professor Wang, continue with your case.
Okay, this is a 67-year-old thin woman. As you say, the patient had the symptoms of palpitation and short of breath for the recent 2 months. And the patient had a surgeon procedure for pulmonary tuberculosis 16 years ago for the resection of the left lung. And the patient had a New York Heart Association classification 3, and NT-proBNP BNP is more than 20,000. And low EGFR, and the STS score is almost 14. It's a high risk for the surgeon, I think, but the patient with a severe AS, mild AR. I would like to show this is the ECG, sinus tachycardia, some STT change, and this is echo. From the echo, you can see the mean gradient not too high, it's a 37. And for this case, we can see the echo, we measure, this is a CT. This CT shows the annulus area is about 588, it's relatively bigger, and LVOT is a 607. And one big calcium in the middle of the annulus seems like the lazy leaflets. We can see the very calcified. And look at the aortic road it's the bicuspid type 1, right to the left fusion with the calcium ruffer. This is a coronary artery at low risk, I think. The sinus of Valsalva and STJ both are big enough. The calcium is very severe. And because of the resection of the left lung before the cardiac transportation to the left chest, and the apex of the heart almost point anterior position instead of a left and inferior position. The aortic arch almost forward, and it seems like a coarctation. Yes, but the peripheral access seems good. The diameter is big enough, good for the transfemoral TAVR. So this is our brief history of our patients. I would like to raise a question. The question first to Professor Chen Mao. How would you treat these patients, TAVR or SAVR?
I think just based on the age, maybe the SAVR is a possible choice, but according to based on the whole situation of the patients versus the high STS score, so this is absolutely high risk, high operational risk by aortic stenosis patients, and also the patient have the long surgical history. So to me, I think the patients absolutely is right candidates for TAVR procedure, but just because the anatomy is not very frightening, so we should plan a very good strategy to treat this particular patient.
Okay, so another question to Professor Tang Yida. If it's a TAVR, which device And you prefer the self-expandable or balloon expandable?
So the patient is an old female with a very low weight, and even we have the femoral accessible, but still the angle between the left ventricle and the aorta is big. So I would choose the balloon expandable valve.
Okay. So also a question to Zhang Junjie, Professor. What's according to the feature of these cases? Any other question?
Actually, just as you introduced, it's a high-risk patient, and also from the CT analysis, it's very, very calcified, and also, so according to the size selection, according to the aneurysm, actually, we should select the big valve. But when we consider a high calci score, and also it's a typical type 1 BAV case. For this case, I think downsize is very important. Actually, according to the supraannular analysis, at the 6 millimeter level, I noticed there is a ceiling level for 26. So for this case, I think we should downsize for the valve. Otherwise, there will be risk. There will be risk. Not only the valve on expansion, but also maybe the annular injury for this case. So
okay,
that's my
thank you.
option.
Very good suggestion. Can I have my slide again? So this is a very true, very calcified cases. I'm sorry, I can't back to previous one. I have to. Yes, sorry. Okay. According to the annulus area, it's very big. I think it's suitable for 29 sapping stray. But I think the sapping stray is too huge for these patients. Okay. Yes. Yes. So we would like to use sapping stray 26. If you use a circle method to choose a valve size 26 sapping stray seems perfect. We could anchor the valve super annulus. Both anchor and ceiling will be super annulus. I think it's a 3 millimeter to 4 millimeter anchor there. If we choose the 29, it seems I worry about the calcium, the roughy in the 3 millimeter high. So consider about this. I would like to yes. This is operation. We need to have a very good view adjustment. The major view angle is the most important in these patients because of the special anatomy of the cardiac and chest. So we check the AP, LAO, RAO before the procedure. You can say seems a very strange angle for it's not normal. We find the co-plan view, but the good co-plan view is very important, but it's difficult for these patients. We check the regular row of RCC in the middle. Seems LAO 57 and Codo 8 is suitable, but I think we need to change another co-plan view. The next one, yes, this co-plan view. We would like the LAO 35 and Codo 20. The RCC is not in the middle, but I think it's more convenient for our operation. So the next step is not too difficult to cross the valve. Yes, and we put a pigtail inside to exchange and make a stiff wire there. We do a aortic angiogram. You can say a mild regurgitation, and also did a airway angiogram. Airway angiogram shows dilated airway. Yep. this we exchange stiff wire. Yeah. Yeah. So because next few minutes we use the sapping wire. You can say, okay, pre-operation we use the dilatation. Sorry, I'm not. This is a pre-23 balloon to dilate it. We can a very clear neck. Now we after that I put the sapping tray valve inside. You can say, I don't know how come it's stopped. I'm sorry. Yes. Okay. Anyway. After the balloon, after the dilatation, we can see so we put a very, before we put the 90-10 position, and after the dilatation, you can see almost 0. It's 110, 100, only maybe 95 position. At this position, we do the aortic angiogram. You can show the mild regurgitation. Because we use -2 cc, use 26 sapping valve. So I think we can add 2 cc with a normal. So next step, I dilate it again, use a normal size, add 2 cc. So this is it should be the final. Yes, I think it's a mild regurgitation. I think this is the final result. I think it's during the catheter measure, we can see the high gradient before operation. Before is a 72 millimeter gradient, after is a 2 millimeter, and after is a 2. And we can say after several days follow-up, the echo says the peak, the mean gradient is 8. And left ventricular, the diameter is decreased. And after the follow-up, the EKG is better. And during 6 months follow-up, you can see it's much improved. The EV ejection fraction raised, and left ventricular diastolic is 45, and the mean gradient is about 6. The patient is a very good condition during the follow-up, and you can see the ECG, the sinus rhythm without any bundle branch. I think this is our results. The patient is a very good condition now. Thank you.
Thank you, Professor Wang, and a very interesting case and so education. I think to this particular patient, we need some question to discussion. First, I think just based on the particular anatomy, the type 1 bicuspid patients, how about the difference between the type 1 bicuspid patients TAVR procedure compared to the tricuspid? And the second question about the downsizing is more generally in self-expanding device, but to balloon implantable device, it's not a generally strategy. And which kind of patients you were using the downsizing using like in balloon implantable device?
Okay, for me, because the very calcified and the roughy there, I worry about the rupture of the annulus and the rupture of the valve. So we have to downsize a little bit. So I think use the circle method is the best way for these patients, and or relatively high position should be better for these cases. Even use the balloon expandable valve. It's similar with the self-expandable valve. I think for me, I think it's what's your suggestion for these patients?
I think the downsizing, also is real in the balloon implantable device. But like you have said, to some like the heavy application, very powerful roughly in this particular situation, we will downsizing just based on the individual case. And one question to Junjie, like in this particular patients, Professor Wang uses the 19:10 ratio, and in your case, you're using the 80:20 ratio. So, how to design the plan? Which implantation tips you were using in bicuspid patient?
Yeah, I think it's a very, very important question. The regular implant ratio is 80:20, but for this particular case, just as Dr. Wang introduced, it's a highly calcified aneurysm and the leaflet, and all type 1 BAV case. So we decided to choose a downsize, and also the angle and the ceiling zone and the angle zone is just at the level superaneurysm from the 4 millimeter to 6 millimeter. Considering as this scenario, I will highly implantation for this case 90:10.
I think we have seen two very excellent cases, especially this second one was clearly a high-risk case. So whenever you see this phenomenon of a lazy leaflet, meaning you see calcium in the LVOT where there shouldn't be any calcium, this is an alert signal that you have a really high-risk landing zone, and you need to think of the strategy of doing downsizing. We have heard the term now many times. So downsizing is something that at first glance sounds like a negative thing, right? Downsizing means you go for smaller valve, might be making compromises in the hemodynamics. However, the opposite is the case in the bicuspid anatomy. I think that's one of the most important take-home messages from this webinar. If you have a highly calcified landing zone, you use the circle method, you get the impression it might be safer to go with the slightly smaller valve. This is not something negative. So downsizing is maybe not the appropriate term. It is actually true sizing, because what you do is you adjust the valve to the given anatomy. So coming also from a surgical background, I can tell you how these valves look in real life, and it's a very wise decision to go with a slightly smaller valve. And you've seen you have full stent expansion on the last case, no regurgitation, no relative leak. So this was the absolute correct decision. And if you would have chosen the larger valve based on the typical annular dimension, you most likely have created annular rupture. So this is why this is a perfect case. So in addition to sizing strategies, we also need to discuss a couple of more things in regard to the bicuspid patients. And this is why we also, in the interest of time, we need to move on to the next topic, which is going to be covered by Professor Chen. And this is techniques of TAVR in bicuspid cases with horizontal aorta. We all know they often have an adjunct pathology of the ascending as well, leading to a nasty horizontal aorta. So please tell us how to overcome these issues.
Yeah, I think this discussion and about the strategy of the horizontal aorta. So this is most prevalent in bicuspid patients. I think this situation, the challenging situation. First, we can choose the particular device like the balloon implantable, just because the fibrosis is short stent, so it's very easy coaxial. And the second, in some situ, particular, it's very difficult case. Sometimes we were using a Snell. Just using this Snell technique to help us to overcome the possible difficulty of the horizontal aorta. How about your opinion, Professor Wang?
You mean for the horizontal aortic?
Yeah.
I think most of our cases for the horizontal aortic aorta, we do, if the patient's suitable, we do like use self-expandable like the sapping tray, because we can flex it's easy to cross the wire and make a very co-axis. It's very easy to control. But for the self-expandable valve, sometimes you do need to use the snare to help to cross the valve. Especially when we met the very calcified valve, bicuspid valve, sometimes it's very difficult. Even you do the balloon dilatation, but still you need very difficult to cross the self-expandable valve. So we need to snare to help to cross the valve.
Okay, thank you, Professor Wang. Thank you for your opinion. And the next lecture, I think I will invite my co-moderator, Professor Georg Kempfert from Germany, should ask the circle method in bicuspid patients. Welcome.
Yes, thank you. I think the circle method has been mentioned a couple of times now, so it's my privilege to maybe give you a little bit more detail into this quite important topic for doing sizing in bicuspid valve anatomies. So before we do so, let me also show you a perspective from the international registry on the outcome of TAVI comparing tricuspid and bicuspid. So if we have a look on the SDS-TVT registry, summarizing more than 10,000 patients, at first glance, there's absolutely no difference in the short-term outcome, tricuspid versus bicuspid, and even it looks like the bicuspid are all outperforming the tricuspid patient. But this is due to the fact that bicuspid patients, as it has been mentioned, also being seen in China, are typically younger, meaning that the long-term outcome is going to be always better. More importantly, we now need to do a matched comparison, and this is a propensity score matched comparison of bicuspid and tricuspid patient using the self-expandable Medtronic platform. And again, the outcome is pretty similar in regard to mortality, but if you have a closer look, you see that in bicuspid patient, you have a higher percentage of significant PVL. So PVL is a problem, and it's due to the fact that these landing zones are often quite calcified. Now, if you look at the same propensity score match comparison, again, tricuspid versus bicuspid patient for balloon expandable SAPIEN platform, you see, again, no difference in midterm mortality. However, the same picture, slightly higher risk for significant PVL. Also, the numbers are perfect or almost perfect. 1.5 percentage PVL is definitely a very good outcome, but still you see also that the risk for conversion to surgery, mostly due to the fact of annular rupture, is significantly increased in bicuspid patients. So this means TAVR is a very good alternative for bicuspid, and we have some first data proving this. However, it also tells us that there are some bicuspid patients that we need to be a little bit more cautious than in the others. And this is based on the underlying anatomy. We all know the different classification systems. So based on the surgical classification on Hans Sievers, it is either type 0 or type 1. The type 1 left-right is the most common you're going to see. But for TAVR, more importantly, it is the actual dimension on the annular as well as the supraannular configuration of the calcification patterns. And there has been the Bavard registry that came up with the classification into a tube, a flare, or tapered anatomy. And a tapered anatomy means that the supraannular structure are more narrow than the actual annulus. And in those scenarios, you definitely need to use some sort of supraannular sizing method in order to find those patients where it is actually be safer to use the smaller valve, often referred to as downsizing, but I like to call it true sizing because the anatomy is something you can't change. And then more recently, there has been this excellent paper by Yoon and colleagues. And what they did here is they compared the outcome of TAVR in bicuspid patient based on the underlying anatomy. And you can see one subgroup of patients here, this is the red one, and they have excess in mortality. And the reason for that is that in those patients, you have heavily calcified landing zone, especially a calcified raphe or these lazy leaflets, they have a high risk for annular rupture. And in those cases, we need to adapt the strategy. And one option to adapt a strategy based on these high-risk cases, again, it's those with high calcific load and those that have a tapered configuration. So those where the supraannular structure are more narrow than the annulus itself. And in those cases, we need to use the so-called circle-based method if you want to go for balloon expandable device. Just be aware if you're whether or not you use Sapiens 3 or Sapiens 3 Ultra, the skirt height is somehow different, and this might also alter your decision-making if using this circle-based sizing method. So these pictures have been shown before. This is a classical case, a type 0 bicuspid anatomy, not too calcified, but still a good example on how the circle can be used. Now what you do is you do in the 3 millimeter increments from the annular level up to the sinotubular junction. You do a kind of a simulation of a circle of the two different valve sizes that you potentially consider. In this case, it's a 26 and a 29. And usually at the level of 3, 4, or 5 millimeter, you sometimes see that this circle is touching the commissures. And if you see the circle touching the commissure, this means you actually can go for the smaller valve size, and the likelihood that this one is going to seal is very, very high without having the risk of pacemaker and, most importantly, annular rupture. So as a kind of a summary, tips and tricks and technical configuration, if you want to tackle bicuspid anatomies, it's very important to have a coplanar view, which is often difficult to get because if you have a type 0, it's very hard to have the 3 sinuses because there are only 2. One strategy is to use a second pigtail if you have problems to orientate yourself. Then you should always go for a balloon valvuloplasty in case you have a high calcific load, because otherwise you can run into trouble in retrograde crossing and need to use body wire techniques that you want to avoid. Also, you can use this balloon dilatation to verify your true sizing concept and add another shot of contrast. And then if you are in doubt with any kind of valve sizes, always go for the smaller valve. This is the one that is going to work and is going to be the least dangerous approach. So also it is important to go for true sizing, so go for the smaller valve, because only then you can ensure circular stand expansion, which is going to avoid the phenomenon of pinwheeling of the leaflets, which might have a significant impact of midterm durability. And then the last point to discuss is the actual valve position. Embrace a supraannular sealing concept, which means you need to aim high, as you also have to expect an early valve anchoring. And this has been excellently demonstrated by especially the second case, whereas in the first case, decision-making was a little bit different, because there you always had the problem of low coronaries, and this is why the operators in this case very wisely chose a slightly less aggressive approach to not have the sealing skirt that high. And with that, I really thank you for your attention, and I hope that more of us are going to use the circle method in the future, because it's the safest approach to treat bicuspid patients if we're going to use the balloon expandable platform.
Yeah, so that's a wonderful talk. So based on the data regarding the Evolut Pro and Sapiens 3, seems like BAV, the PVL, more happens in the self-expandable valve. So in this case, should we consider more balloon expandable valve or platform than the self-expandable form for this kind of patients? I mean the BAV, and the BAV patients has more enlarged aorta or the more calcified.
So in my point of view, the balloon expandable platform is best suited for bicuspid valve anatomy. And there are 2 reasons for that. Number 1, the sealing in general is better, but it requires a very careful sizing process. So if you do the circle sizing, I think it is safe to use balloon expandable, and you get rewarded with less PVL. At least this is our experience in Berlin. And the second reason to go for balloon expandable is that those patients are often slightly younger. And in the younger patient, we definitely have to worry about maintaining the coronary access, not only for emergent PCI, but also for potential valve-in-valve, so TAVR and TAVR down the road. So 2 reasons why I like to use the balloon expandable in bicuspid anatomy.
And I like the idea about the, do we have time? And an idea about the true sizing instead of the downsizing. So for the case you mentioned, actually that would be like the 29, actually Dr. Wang Yan's the case, the second case, but we choose the 26, actually is a downsizing already. So, but we actually, it's not the standard volume, with the -2 volume instead of the standard volume. So what would be the case in your experience if you do the case?
So we would have used exactly the same approach. We would have used the 26 based on the circle method. We call that true sizing. We would have used maybe an additional contrast shot during the valvuloplasty to reassure and reconfirm that the smaller valve is going to seal. And then the question is, do you want to take it slowly, which would mean you would go for less nominal volume, which is a good approach. And then you can always post-dilate if the result is not perfect yet. This is the more cautious approach. But once you get more, maybe more used to the circle-based sizing method, and you build more trust into this approach, you most likely can also go for the full nominal volume if you have done the CT analysis correctly.
Thank you.
Thank you very much. Thank you. I think we have a wonderful webinar today, and thank you. We have 2 wonderful presentations and 2 fantastic cases. And I think finally, take-home message from this webinar: bicuspid aortic valve is noted in about half patients undergoing TAVR in mainland of China. And the TAVR in bicuspid patients is a technical challenge. Fortunately, both self-expanding and balloon expandable device have achieved satisfactory results in this particular group patients. And I think no matter what, which kind of device you use, the valve sizing is of a critical importance for TAVR in bicuspid patient. Most self-expanding device we're using the supra-annular sizing, and I think to balloon expandable device, circle methods is a good choice to help us to choose the right size of device. And finally, thank you everybody, and thank you all audience joining our webinar. So we must say bye-bye to everybody. Thank you very much. Thank you for your joining.
Thank you very much.
Thank you. Bye-bye.